Commence now with just an ABF update. So what work have we been doing during the year, and I suppose why are we doing it? So broadly, I'll go through just our implementation plan, which was really developed based on the requirements from Sláinte Care. Quick ABF update in relation to changes we made this year. The benchmarking model outturn itself, just touch on hospital level reports. Mark will deal with that in more detail. And just some other ABF related work in the HPO. Stephen's mentioned the kind of UAN piece. So the implementation plan itself, basically Sláinte Care was driving that. We set 35 actions, most of which we are dealing with on an ongoing basis, including the transition hospitals further to ABF. That came from the plan itself as well, coming from Sláinte Care. Expand ABF for inpatients in day case for acute hospitals. So we've gone from 38 hospitals in ABF to now 44. We've got hospital local implementation plans, publish a price list and consult annually for transparency in the price. That's our pricing framework document. Continue to review and refine the ABF pricing model and methodology. That's our consultation document that I'll refer to later. And look at new classification systems for ED and outpatients, which again we'll cover. So really improving data and data collection, because that's the key around this. And it's the data is allowing us to, because we adjust for complexity, link that to our spend and be able to account for what we spend. So we can show complexity has increased year on year. And that's important when we are challenged by our funders that, we're able to show this information. There's no black holes, particularly in relation to the ABF component of our spend. So just our update, I mentioned the pricing framework. And I think this is important. This is a document that really sets out what we do. So it covers essentially the strategic approach, it covers the classifications we're using, the costing process, how the price is set, how we work with the co-payments, and the annual consultation process. So really, we update that every year to reflect the changes that we've made in a current year. So again, that'll be on your price list, on the website. We have a consultation document, which will be covered in a later presentation, but broadly setting out the proposed changes that will feed into this year's ABF benchmarking. We've done some work around quality-based framework. So again, using ABF to improve patient care. And I think Stephen's mentioned what we're doing here, the patient should be at the centre. And anything that we can do in relation to quality needs to come in, whether that's as they do in Australia around hospital-acquired complications, where they adjust funding downwards if complications happen during the hospital. We have done some work in that area. We're working on cleansing the data at the moment, but also it can be used for the likes of best practice tariffs. We have a best practice tariff for hip fracture at the moment, and indeed any other areas where we can use the data or use the funding to incentivise good quality care. We've updated our coding and classification system. Our coding to version 12, so all the coding people in the room would have been aware of this is the major change, and a lot of training on behalf of our team in relation to, we've over 300 coders in the system, so they all have to be trained in the update. And the reason we do this update is keep up to speed with changes in medical practice. On the coding side, we changed the DRG classification as well. So again, that's the DRGs, which decides on the complexity of patients. Again, that changes because the cost of care changes, and we have to keep up to date with that. COVID obviously has impacted quite a bit in that period. We use an Australian classification system. So again, we take the updates from Australia, but we do adapt as appropriate to reflect Irish practice. All coders were trained. Our IT team would have developed an ebook to go along with the coding. So again, that would have coding commenced on the 1st of January 2024. So you'll be well aware of that in the coding arena. Stephen has mentioned about the linking of funding to NSP targets. That was broken during COVID. So now we have an NSP target that links in with the funding. And that's then used for monthly reporting. So Lauren and our team produce a ClickView document monthly that hospitals have access to, which records our actual activity against our target. So it allows our NSP activity to be profiled monthly and by hospital to report against target. So that's important to get that link back. Outpatients, we've been doing some work on this here in the UL group, and I thank the UL group for their work on this. We're coming to conclusion there as well with the pilot. And that pilot was basically determined to see if the classification was fit for purpose, but also it's recognised the fact that we need to set up the clinics on the PAS system for existing clinics and new clinics that are being set up. So that is a piece of work, but it's important to expand that now to the other groups and regions. And I think the system, obviously, to be part of the ABF process, will have to be mandatory. But it certainly gives us more information in relation to what's happening in outpatients. Typically, we report at the moment at specialty level. That needs to move now down to the clinic level, so we get better granularity in relation to the cost to activity relationship. Same in the ED. The pilot took place in Tullamore. Again, this was proof of concept for the classification system. Both classifications for outpatients and ED come from Australia. And that's because, it makes sense for us to take other countries where they have spent the money investing in it. We buy the license off them, and we can adapt as appropriate. So again, for outpatients and ED, we can make adjustments to reflect Irish practice. We have had kick-off meetings to expand it to South-South-West group, Dublin Midlands and Ireland East, and remaining groups to take place in June 2024. So again, the collection of the data will be important, and we're hoping to start, have the initial meetings with all the groups finished, and that we would start collecting the data then by the end of the year. Stephen has mentioned the board strategic scorecard. So just changes to the model. I've mentioned the move to version 8, version 10. We also made some methodology changes as per the consultation process from last year. So this is where the consultation feeds into the actual change. And the two big ones were the adoption of the common weighted unit for inpatients and day cases. And I think that was always a challenge around. You couldn't compare weighted units for an inpatient against day cases because they were, apples and oranges essentially. And hospital grouping in the model as well. So we can comparing like with like when it comes to hospitals. The price list also is the first price list that is effectively post-COVID. So during COVID, we carried on the process, but we couldn't use the prices that were coming from the cost data because obviously the activity had dropped, the cost had gone up because there was a lot of COVID expenditure in it. So in that period, we would have just inflated the price list for those years. So essentially, this is the first year we're back using the costs as the basis for setting the price. And that's been complicated somewhat as well with access to care. And Stephen mentioned different funders and separate commissioners. That's a challenge as well when it comes to the price list. So I won't dwell on this because this is in a later presentation, but broadly the number of DRGs changed from 807 to 795, but there were a number of changes within that. It wasn't just a change of 12 DRGs. And I'll cover that later. The common weighted unit, I've mentioned that already, and there's an example here that really just gives I'll leave this in the slides for you, but essentially what it does now is that the price hasn't changed. That's the important thing. So the price we pay for day case doesn't change. The weighted unit component does. So basically what's happened is the inlier weighted unit and the day case weighted unit are now comparable. So we can compare like with like. And I know the department tried to do something like that in the context of the IGES report that Stephen mentioned. So, but it is an important first step, and it does change the way in which we report. So I think now when you see a weighted unit, whether it's an inpatient or day case, you know that it's similar. Hospital types, again, we looked at the different costs that were coming out of the hospital types. So this year we have 6 groupings, and typically Model 4s, Model 3s, Model 2s, paediatric, but we always had a separate paediatric adjustment for paediatric hospitals because they're so specialised. Model 4s, there used to be a tertiary referral adjustment, so we just put them in a group that takes away the tertiary referral adjustment. So essentially we've got the same base price, but we've got a factor for each hospital type. So the outturn, the ABF outturn for 2023, I have it there in the slides. Again, Stephen's point around the transition adjustment. It is 85% transition. The reason transitions are brought in is obviously to, I suppose, act as a sort of parachute when you're still developing the area. And also in 2022, we still had a lot of COVID in 2022. In fact, we had more COVID cases in 2022 than we had in 2021 and 20 in our hospital system. I think about 35,000 cases. And the impact of COVID is that our length of stays typically for COVID patients were almost twice the norm, and also longer stays in ICU. So that's the reason why you would put transition adjustment in. Obviously, Sláintecare has asked us to take it down, and that's something we look at. I suppose that also could be part of the consultation process. That's a very busy slide. I won't dwell on it, but basically that's showing all the hospitals, all our cases, our weighted units, our co-payments for oncology and agency, our DRG value, and the same position then as I've mentioned previously. That's just an example of Model 4 hospitals. So again, the models are kind of budget neutral within each model area. So you're comparing Model 4 hospitals against Model 4 hospitals, and that makes it easier when we come to compare then the analysis that Mark will present in the next presentation around when you're trying to understand hospital performance, you're comparing against your peers rather than comparing, St. James's against, a smaller Model 2 hospital. So hospital level reports, time. On ABF performance, again, relates to 2022 costs and activity. And that's also the last full year. So we did in the past in ABF try to work in the current year. So when we were doing this in 2023, our last full year cost data was 2022 in activity. We did try to do it on forecast data, and I think we had a number of challenges around the accuracy of forecasts. So that's the reason we would go back. And look, internationally, most countries would have that gap because you've got a fixed year then of costs and a fixed year of activity, and that's where you base your relativities for setting your prices for 2024. So Mark, the reports are trying to aid understanding of ABF performance, which is impacted by many factors: total spend, how accurately that spend was costed, because obviously within our total expenditure, we have ABF expenditure, non-ABF expenditure, the volume of cases treated, coding completeness, coding quality. Average length of stay is a key driver. We're talking about efficiency and productivity. Then I think average length of stay becomes very important. But what does average length of stay mean? If a hospital is 6 versus another hospital is 7, I think you have to be able to drill down to DRG level, to look at it by DRG to see where are you out of line with your peers. Just saying drop your inpatient stay by 10% is not realistic. So Mark will take that in more detail. Other work, again, Stephen's mentioned the IT-based UAN and claim system. And this was certainly something we soldiered during COVID in relation to paying the private hospitals for services. And Jerry would have been aware of this and around. VHI came in and made the payments on our behalf because we didn't have a system in place. So Brian and his team have developed both a UAN system, which is like a PO, it's an authorization to treat, and then a claim system that the private hospitals have to bill with and link to the UAN. And that's been done for surgical services. So again, where we have a price per procedure. It's done for outpatients, medical beds, where we're just taking the number of beds. That's done in a day case, a cost per bed day. It's involved as well then in assisted human reproduction. And the next phase is looking at the public hospitals, where again, the department are asking us to identify additional activity that takes place for access to care funding. So this is the point back to about separate commissioners. So how can we identify that the additional activity was carried out for the additional funding that you received? So I think the UAN system gives great reporting capability that wasn't there during COVID and other uses of private hospital services, where we're depending on spreadsheets coming in from the hospitals. And if Mary was out 1 week, we got no report from that hospital. So Brian will go through that in more detail. I'll just mention as well the HPO website that is under development and ready for release in June. And all today's presentations and documents will be uploaded to this website. So broadly, I'll just a couple of screenshots first. We very much, to be fair to say, again, looking at our Australian colleagues, there's an equivalent organisation in Australia called the Health Care Pricing Authority. They might have changed their name since. But broadly, we look at the home, the ABF funding. So again, use the roadmap for easier. So we look at the implementation plans, the guides and presentations, any documents that are uploaded, and the documents for the various conferences. So that comes under ABF. Under services, again, there's a page there around what we do, HYPE, NPRS, patient level costing, and any events then that are in relation to training, our HYPE training calendar, costing likewise, we'll put up there. And there's even a link to the YouTube. So essentially the presentations will go on YouTube. So, so that's ready to go in the next couple of weeks. So I'll leave it at that and try.